Anthropometric training.
County collaboration. This presentation has been developed in collaboration with the health plans listed to the right, reflecting the collective efforts and contributions for all parties involved. Learning objectives. By the end of today's presentation, everyone will be able to use the appropriate growth chart based on the child's age, understand BMI and how to calculate it, read and understand percentiles and growth charts, recognize when intervention strategies need to be implemented, and lastly, be able to discuss this sensitive subject with children and caregivers in a way that feels supportive. Who needs to be trained? All providers and staff involved in screenings, as well as those responsible for training others. Frequency. The training is required for all new hires and must be repeated every 4 years thereafter. What does monitoring a child's growth tell us? It tells us if the child is receiving adequate nutrition. It determines their current height-weight status and screens for the potential of obesity. A child's growth assessment is the single most important tool we have to establish their health and nutrition status. BMI screenings could present an opportunity for education and intervention. BMI explained. When calculating BMI for people 21 years of age and older, we use just height and weight. Some resources might include age and gender, but with children, it's a requirement. Using these screening tools is a fast and easy way to determine which category that child is in. With time and continued monitoring, a provider can also recognize when intervention measures should be taken. Being in one of these categories is an early indicator for future chronic conditions like diabetes, hypertension, and hyperlipidemia. In some cases, a child may fall into the underweight category, and further assessment is needed and possible screening for eating disorders. These are guidelines from CDC's website for getting accurate height and weight measurements at home. In order to get an accurate measurement, we should ensure the child doesn't have any shoes on, no bulky jackets or clothing, and hairstyles should not get in the way of getting a precise measurement. It should be done on a non-carpeted surface with flat feet and heels against a flat wall, so not touching any baseboards or molding. The child's head, shoulders, buttocks, and heels should be touching the wall or stadiometer, and their line of sight should be parallel with the floor. Lower the flat headpiece until it firmly touches the crown of the child's head and forms a right angle. If at home, the measurement would be marked on the wall and then measured using a metal tape. You have equipment in your office to accurately do this, but this is useful information to pass along if a child's progress needs to be monitored at home. Be sure to record the measurement to the nearest 1/8 inch or 0.1 centimeter. This is the imperial measurement system we typically use in the United States. We have 1/8 inch, 2/8, which converts to a 1/4 inch, 3/8, and so on. We are going to record to the nearest 1/8 inch. In this example, if the measurement falls here, we would record this as 7/8. For children too young to stand, we're going to measure length. This is best done with 2 people, so either 2 medical providers or a medical provider and a caregiver. One person will hold the child's head against the headboard, while the other gently stretches both legs straight. If both legs can't be positioned, one leg is acceptable. Ensure the baby's feet are at a 90-degree angle with the toes pointed upward and record to the nearest 1/8 inch. There is a specific medical condition we're looking for when we measure head circumference. Hydrocephalus is a neurological disorder caused by abnormal buildup of cerebrospinal fluid deep within the brain. This can cause harmful pressure, but if it's caught early and the infant undergoes surgery, they will not have a shortened life expectancy. Children's heads should be measured from birth to 2 years old. Use a specific tape measure like this one that loops around into the notch or simply non-stretch. Again, recording to the nearest 1/8 inch. You'll be measuring approximately 1 to 2 fingers above the eyebrow and around the widest part of the back of the head. Measure 3 times and take the largest number. Just like with measuring, when weighing, we are going to remove any bulky or heavy clothing items. Per CDC recommendations, a digital scale should be used and spring-loaded scales avoided. The scale should be on a firm surface and feet centered. Record the weight to the nearest decimal fraction. For weighing babies, the scale should support the infant and have the capacity up to 35 pounds and be easily zeroed and calibrated. Note that calibration must be done annually. The baby should be fully undressed or be in a clean diaper only. Once you have your measurements, what chart are you supposed to use? An easy way to remember is birth to under 2 years old, use the WHO. 2 to 20, use the CDC. And again, gender is important, so they've color-coded them to quickly determine if you're looking at a chart for a male or a female. Once you have your age, height, weight, and the correct chart in front of you, you plot your point. Let's imagine we have a baby girl that was 8 pounds at birth. This single point indicates the current status of that child. At her 3-month follow-up, she now weighs 13.5 pounds. She is on her same expected growth pattern, continuing to follow the 75th percentile. Now, if at her 9-month visit, we see her fall below her current percentile, we may wonder, well, what's changed? Maybe she got sick, or if she's breastfed, mom's supply dipped. It's worth looking into more. However, anytime we see this, we should think, if not following the trend, check it again. Recheck your measurements, but also recheck your charting. It's possible a referral to a lactation consultant or specialist is in order, but the easiest thing we can do is to check it again. Now, if a baby starts out in the lower 5th percentile and then continues on that path, that could be their normal. As long as the child is eating and gaining weight appropriate with their percentile, continue to monitor and keep record at all well-child visits. Let's review percentiles. A percentile is a measure that helps us understand the position or relative standing of a particular value within that dataset. It sounds confusing, but it's really simple. Another way to look at it is it's a comparison score between a particular score and the score of the rest of the group. Most babies are in this middle range, while a smaller percentage are on the low and high end of the spectrum. But most are right here in the middle. That's why it's pretty easily understood when we say someone scored in the 50th percentile. It's middle of the road or average. Let's use our previous example with the 8-pound baby. She's in the 75th percentile, and that means she weighs more than 75% of the baby girls born. It's a comparison of that female infant to other female infants. Now we're going to talk about adiposity rebound. This is the point where a child reaches their lowest BMI before it starts its gradual increase. As you can see on the chart here, there is a normal increase in BMI until age 2. Then it begins decreasing and reaches its lowest point, somewhere between ages 4 and 6 years old. After first or second grade, the BMI begins a gradual increase through adolescence until the child reaches adult weight and height. This adiposity rebound is important, and you're going to see why on the next slide. This is an example of what happens when a child follows the BMI growth curve until 4 years old, and then their BMI starts to rise above what their current percentile was. Without intervention, excess weight gain is likely to continue. If, however, intervention is started at the 4-year-old visit, the upward trend may be prevented. It might be as simple as discussing if any beverages being consumed could be substituted with water or extra physical activity incorporated. See how the intervention got this child back into a healthy BMI. This chart shows the ranges for underweight, healthy weight, overweight, and obese. Another great tool for calculating a child's BMI is to go to the CDC's website. It's very user-friendly. You can simply choose the gender and type in the child's age, height, and weight, and it calculates the percentile for you. Behavioral health can have a huge impact on all ages. It can present itself in a variety of ways, such as avoidant restrictive food intake disorder, ARFID, anorexia. Anorexia can be seen as anorexia nervosa or atypical anorexia, depression, anxiety, obsessive compulsive disorder, OCD, post-traumatic stress disorder, PTSD, etc. Some signs and symptoms to watch out for in patients at risk for an eating disorder are rapid weight loss and gain, low heart rate or fast heart rate, preoccupation with food and body image, Russell sign in bulimia, where the knuckles are scarred from the acid from purging, anxiety, depression, and rigidity in all aspects of life. Children as young as 5 have been diagnosed with mental health issues. Some questions that can be asked when screening are, have you noticed any compensatory behaviors such as overexercise, going to the bathroom after every meal, etc.? Have you noticed any preoccupation with food or body image? There are a variety of screeners that can be used to identify risk for eating disorders, such as SCOFF, Sick Control 1 Stone Fat Food, Eating Disorders Screener for Primary Care, ESP, Eating Attitudes Test, EAT 26, or Adverse Childhood Experience Questionnaire, ACE, for positive trauma. Individuals at risk for eating disorders are athletes, performers, individuals who have experienced trauma, individuals of all genders, etc. So, how do we approach a patient whose BMI results are concerning? Honestly, having weight-related discussions can be uncomfortable for everyone involved, but there are techniques to make it a little easier. Take the focus off weight. Talk about focusing on health, but avoiding the discussion may delay the patient receiving necessary evidence-based care. You can give the patient the option to do blind weights to take the power away from the number on the scale. Ask the family if they want their child weighed at all, or if they want the number discussed. Some of the ways we can tread lightly is to ask permission of both the parent and the child. To discuss difficult topics, such as BMI and current lifestyle habits, use words such as health and growth. Ask about what the perspective of the family is regarding health and collaborate utilizing a solution-focused approach. If possible, include the child in the conversation, depending on their age and development, and other stakeholders such as other family members, parents, and providers. Use appropriate non-labeling language. Stay positive and utilize motivational interviewing techniques. Spend a couple minutes at each well-child visit to talk about what they're doing and what we could still work to improve upon to improve their health. Examples might include more vegetables, improved water intake and different beverage choices, increased physical activity. Also emphasize that getting adequate sleep is very important. If their weight issues are due to an eating disorder, such as binge eating disorder, modalities such as cognitive behavioral therapy and dialectical behavioral therapy can be helpful. Let them know that the focus is more about having a healthy body that has energy and feels its best, and less about how the body looks. References can now be found on the next 3 slides. Thank you. Your participation is valued. Please share any feedback, questions, or concerns.